So Dr. Newsome is next. He is on faculty here at Hopkins in the multiple sclerosis and transverse myelitis centers. But of course, as to be expected, there was a detail that I forgot about. So while Dr. Pardo is actually passing around some note cards, so at the end of today, you all recall that there are breakout sessions, and I would like, if you all have any questions that you plan on asking at these breakout sessions, if you could just write them down if you know of any of them that you have right now. And if you know which session you're going to, if you could write down which at the top for which session it is that you'll be asking this question. So the three sessions, just to remind you, are NMO, bowel and bladder, and spasticity. And so if you could at the top write for which session it is that you're asking the question, and then write your question, and this will help to direct the conversation for each of the people that are leading these discussions. And then you can pass them to end of the aisles, and I can sort them and give them to each of the directors of those discussions, and it'll just help them to facilitate those discussions. And without further ado, Dr. Newsome, please.
Thank you very much. Can you guys hear me? Okay. Michael's a little bit shorter than me, so I'm going to have to pull this up a bit. Oh, great. Thank you. So what a great way to round out presentations with talking about pain in transverse myelitis. And as most of you are familiar with, the majority of people who have an episode of transverse myelitis or any central nervous system attack will experience some type of pain. So we're going to review that. And I preface this talk by saying that pain, in my mind, is one of the most challenging things to treat in transverse myelitis. And hopefully you heard a fantastic talk by Dr. Levy with some of the advent of future therapies, stem cell therapies included. I'm hopeful that some of the pain syndromes that we deal with in TM will improve. But today we're going to talk about how we can improve some of the pain syndromes with what we have available today. So when I'm on rounds teaching medical students, fellows, residents, I always tell the students and residents and fellows that you have to take pain seriously when someone is complaining of it, because pain right now, the way we measure it is on this 0 to 10 scale, which is not a great scale. Each individual will experience pain depending on what is causing it. And so I like this quote. This is by an MS nurse practitioner. Pain is whatever the experiencing person says it is, existing whenever he or she says it does. It's absolutely on point. So how do we define pain? Well, it's not really adequately defined with conventional terms, but what we do say is pain is very complex. It's a sensory phenomenon. And again, getting back to that, it really is a individualistic symptom that we have to listen to. Now, with respect to transverse myelitis, more than 50% of folks will experience pain. And I would say upwards to close to 80% of patients who have had an episode of transverse myelitis will experience some type of pain. And we'll discuss in a couple slides some of the more common pain syndromes. But when we look at acute versus chronic, acute pain syndromes that we see in transverse myelitis are really when someone's having their first attack or maybe even their recurrent attack. Occasionally people will experience this really sharp, sometimes it can be dull, pain in the back. It can be very intense. Some patients will say it's analogous to actually labor pain. And then on the other side, which is in some respect more disabling pain, is the chronic pain that individuals with TM will experience. For example, neuropathic pain. Now, pain in general, as many of you know, pain is mediated by not just central nervous system disease. You can also have peripheral nervous system disease that causes pain. An example is diabetic neuropathy. So unfortunately, there are some of our patients that will have both peripheral and central nervous system pain syndromes. Now, there have been studies looking at the severity of a transverse myelitis attack may contribute to how bad the pain can be. There have been studies looking at, for example, neuromyelitis optica versus multiple sclerosis pain. and showing that oftentimes the NMO attacks, at least spinal cord attacks, can be a little more aggressive, and that can set the platform for more pain down the road. But again, getting back to what I mentioned, pain is individualistic, so no matter how small or large the transverse myelitis attack is, we still take pain very seriously. Now, there's a couple MRIs just to give you guys an example of what a complete longitudinally extensive transverse myelitis may look like. And if you look here on the left, this is a patient who has had attack from neuromyelitis optica. So you can see it's a profile shot here. The normal cord signal should be dark within the spine, which is here. And then as we come down, you'll see it gets bright. And it extends all the way down to the bottom of the cord. So that's a very large longitudinally extensive transverse myelitis. And we look at cross-sectional bird's eye view, you can see this whole cord here in the middle is very swollen and bright. There's a lot of inflammation, a lot of edema. Then if we look at what we term as a partial transverse myelitis, this is a patient who has multiple sclerosis, and you can see the difference here. This is longitudinally extensive, very long, and here is just at a focal area, a focal lesion. And a bird's eye view, you can see it's just one part of the cord. So some of the more common types of pain syndromes we see with respect to transverse myelitis are listed here. Neuropathic pain is probably the most common. Neuropathic pain can involve any part of the body. For transverse myelitis, since we're dealing with the spinal cord, most often it's in the torso region. It can also be in the extremities. Motor spasms, I don't want to gloss over this because I think this is an extremely important pain syndrome. This is, in addition to neuropathic pain, is what keeps people up at night. Of course, pain syndrome, as soon as you're laying down to go to sleep and try to rest, that's when it aggravates and activates. So we do a lot of time trying to control the symptoms at night. Now, musculoskeletal, we'll spend a fair amount of time on this because I think musculoskeletal pain is sometimes overlooked and extremely important in terms of how we intervene with patients. And the musculoskeletal discomfort that folks will experience, gait disturbance. So if someone is walking and they've had an episode of transverse myelitis and the walking is impaired because of that, it's going to put strain on different parts of the body that are not necessarily used to having that much strain, like a hip or a knee. And you'll have focal joint discomfort related to that. Also, spasticity, which many of you have experienced, the pain that comes with spasticity can be quite severe. And so we do a lot of work in trying to control the spasticity, which oftentimes can control not only the pain related to spasticity, but also sometimes the pain that comes from gait disturbance, because if we treat the spasticity, sometimes the ambulation and the walking can get better. So to talk a little bit about neuropathic pain, I don't have to tell probably many of you what this feels like. These are some of the terms that we hear in clinic, that the pain can be burning, tingling, an electric shock, searing sensation. Some of you have probably heard the term the Lermitz phenomenon, where if you flex your head forward, you get this electrical shock that goes straight down your spinal column, very uncomfortable. And this band-like discomfort, for those of you who have multiple sclerosis, people will talk about this hugging sensation. It's like someone's doing a bear hug. All of these can be very, very uncomfortable. As I already alluded to and mentioned, that neuropathic pain is often worse at night, of course, when you're trying to get comfortable. The over-the-counter medications like Tylenol, non-steroidals, ibuprofens, etc., don't treat this type of pain syndrome, because nerves are what are mediating the neuropathic pain. You have to prescribe medications that will help at the nerve receptors. And oftentimes we need multiple different treatments, including medications and non-medication related interventions, which we'll touch upon. Now, why do we care about neuropathic pain or pain syndromes in general? Well, it hurts, right? It's not fun to have pain. But at some respect, even more importantly, there are a lot of associated symptoms that come with pain syndromes that really disrupt individuals' quality of life. Some of them are listed here. Insomnia, of course, if you can't get to sleep because of the pain, then you're not going to be able to rest, and then the next day you're going to have a lot of fatigue, daytime fatigue, etc. Depression, anxiety go hand in hand with pain syndromes because of where in the central nervous system the pain centers are. They're right next to the depression anxiety centers, and they feed off of each other. And you can see a couple of the other things that are associated with pain. So how do we treat neuropathic pain specifically? There's a variety of things we do. Some medications, of course, and there's a boatload of medications, a very long laundry list, which I'll show you next, of medicines that we try. And oftentimes we'll have to do combination medication therapies where they're working at different parts of the nervous system. I want to point out that there are a lot of non-medication related interventions that are done, which I think for most people are very important. And warm and cold compresses sometimes can help with neuropathic pain. Occasionally you've got to be careful though, because cold compresses sometimes can worsen spasticity. Pressure stockings we've used in some folks, which there's the sensory input from the pressure stockings that can help send back this loop to the pain receptors that can help decrease pain. And acupuncture, I actually really encourage people to do things of acupuncture, tai chi, yoga, because I really feel that these interventions, they've been around for thousands of years. Even though there are not a lot of studies that say, oh, this is how it works, we know from patients who undergo these type of interventions that it actually does help their symptoms. Now, there's been a lot of press on medical marijuana. There are some studies that show that medical marijuana does help with pain, can help with spasticity. The downside to medical marijuana, of course, is sometimes it can make you more fatigued. Cognitively, you can be a little bit less sharp. The good news is, though, there are pharmaceutical companies that are working on medications that take out the extracts of the marijuana that cause sort of the fatigue and the cognitive fogging. So more to come. Here in the U.S., there is a medication that's not approved, that is approved in Europe called Sativex, which some people have said have helped. Now, spinal cord stimulators. Now we're getting into some of the more invasive procedures. Spinal cord stimulators have been used from time to time for intractable pain. The definition of intractable pain depends on who you ask. Usually if you've gone through multiple medications and you've tried a lot of the non-pharmacological interventions and you're still having excruciating pain, occasionally we will send people to get a spinal cord stimulator. Now, up until last year, the spinal cord stimulators that were placed were not MRI compatible. So that became a big problem for those of you who have a relapsing condition. Now, though, as of early last year, the first spinal cord stimulator that's MRI compatible was approved by the FDA. It's a Medtronic device. So I could see for some people this may be a viable option, even if you have a relapsing condition for treating pain. Now, sort of a more barbaric approach, which I can't say personally I've sent patients to get done, is neuronectomies and myelotomies, this is an actual surgical procedure where the surgeons go in and take a piece of the nerve root or the spinal cord itself where the sensory fibers are. Now, like I mentioned, I've never sent anyone for this type of procedure, but reading the literature on this is not as effective as you would think it would be. There are probably about 30% of folks who will come back even after having these procedures with intractable pain. If your pain is related to this disease and you have really bad nerve root compression and you've tried sort of all the conservative therapies, there are these interventions called radiofrequency ablation interventions, which some of you may have had, where the surgeons go in and actually almost like heat up the nerve root and kill the sensory fibers, and sometimes that can help. So I'm not going to go through this list of pain medications. Some of you probably have been on a couple of these, if not many of them. What I do want to point out, though, there are oral and non-oral medications. So there are lidocaine patches that we'll prescribe for people who have the uncomfortable skin sensation to touch. There's also capsaicin cream, which has got cayenne pepper in it. When I was a resident, I had an attending who swore by capsaicin cream for neuropathic pain. And as naive as I was back then, still somewhat naive, I said, there's no way this is going to actually work. And lo and behold, we prescribed it to a few patients, and it seemed to help actually some folks. So this is bought over the counter, doesn't need a prescription. So with regards to pain medications, how do we prescribe these? How do we taper them? This is by no means a written in stone sort of slide. This is sort of how I do things. Other people may do things differently. So usually if someone requires a pain medication, I'll start at the lowest dose possible. There are some people that can get away with just having a very low dose of a pain medication, and that can improve their quality of life. The problem, if you start too high, then that's going to cause side effects, right? And so if you can start slow and gradually taper up as needed, that seems to work quite well. Now, if someone is still having a impaired quality of life because of the pain, then, and they're only on one drug, we'd like to do multi-drug regimens. My personal bias with this is if we're going to prescribe a couple different drugs, try to prescribe drugs that are of different classes of medicine, so they're working differently within the nervous system. And in general, if someone becomes pain-free, which, that pain-free, I should put in quotes, is sometimes challenging with transverse myelitis patients, after a few months, we will taper the medications down. Now, moving on to musculoskeletal pain, as I mentioned, that this can be quite challenging, and most often it results from impaired ambulation from the transverse myelitis. And so if someone has weakness and is still ambulatory, their gait has to change in terms of how it's working. And so patients will, again, they will have strain patterns develop in certain regions of the body that aren't used to taking so much strain, and then they'll develop over time pain from that. We've had some patients, because of immobility, develop, whether it's frozen shoulder, frozen hip, and that can cause quite a bit of pain as well. Some of the treatments that we give people, not necessarily in the acute setting of transverse myelitis, but some patients will require long-term steroids or repeated steroid doses. There are a couple things that can happen where folks' bone health can be diminished from chronic steroid use, and there's this condition called avascular necrosis, which is quite severe. It's analogous to a stroke of the bone. We often will see it in the hip or in the knee. And so if an individual has been on chronic steroids for one reason or another, and they develop fairly acute on chronic hip pain or knee pain, then I usually will do an MRI of that region to see if we're dealing with avascular necrosis. I had touched upon disc disease. This really is secondary to mechanical stress from if your gait is inefficient, then it's going to put strain on your back, more so than it already is picking up strain from walking, and that can cause herniated disc, bulging disc, which then can compromise nerve roots. So similar to neuropathic pain, we will try to treat musculoskeletal pain sort of in a multidisciplinary approach. So prevention, of course, is ideal. If someone has had an episode of transverse myelitis, we're very aggressive in getting them involved in a rehabilitative program that incorporates physical therapy, occupational therapy if needed, and other things. Gait training, we talked about how if your gait is inefficient, the therapist and the physiatrist do a very nice job with almost teaching your body to how to relearn how to walk. There are certain assisted devices that we'll prescribe. So, for example, if someone has a foot drop, an AFO can help keep the foot up, and so you're not tripping. Also, there are different electrical stim devices like the Bioness device or the walk aid that can also help kick the foot up when you're walking. Very important for individuals who are more confined to a wheelchair. I think it's extremely important to have your wheelchair assessed to see if it's properly fitted for you. I have a lot of patients that will get a wheelchair on the outside, then they'll come in, they're complaining about a lot of musculoskeletal discomfort, and we'll send them to our rehab folks, and they'll assess whether their seating is proper, and lo and behold, they end up needing some modification of their wheelchair. And so I think that's extremely important to consider as well. Exercise, of course, and exercise is different depending on what your disability may be. Part of this I will recommend, again, physical therapy, occupational therapy, and physiatry involvement to develop an exercise program that could be helpful, not only when you're at a facility, but very important, you need to exercise at home. We've already touched a little bit upon some thermoregulation type interventions, heat, ice therapy. I've had some people, they'll do hot then cold. Other people will just do hot. So it all depends on how your body responds to the particular intervention. Now, we have already talked about acupuncture. There are other manual manipulation type interventions, massage therapy. All of these, again, I think can help for patients who have musculoskeletal pain and discomfort. And then medications, so a little bit different than the neuropathic pain. We still will use some of the neuropathic pain medications to treat some of the chronic musculoskeletal pain, including like Lyrica or Cymbalta. But oftentimes, if a joint is inflamed, we'll use the anti-inflammatories like ibuprofen, Aleve, sometimes even Celebrex. So there's a whole breakout session on spasticity. So I'll go through this and fairly quickly, but I do want to touch upon this because I think many patients who have TM will experience spasticity. And what is spasticity? So really it's the motor fibers within the nervous system that get impaired from transverse myelitis that sets a patient up to have spasticity. Now usually in the acute throes of a transverse myelitis attack, spasticity is not there. It's usually what happens after the acute inflammation goes down. And one thing to point out is spasticity can happen even a year or 2 years out from the transverse myelitis. And it does not mean that you're having another central nervous system attack or recurrent TM. So that's something to keep in mind. If someone had developed spasticity, though, in my mind, and they've been very stable for a while, I'll still do repeat MRIs to make sure that we're not dealing with a new event. But oftentimes it's not a new event. I had already mentioned that cold temperatures can aggravate spasticity. Oftentimes heat therapy is the way to go. And weakness can be masked by spasticity. So if you have an arm or a leg that is really tight, then our bedside exam is not very useful in terms of trying to assess whether someone's weak in that limb. And really we'll try to do our best to get that limb less spastic so then we can test how strong someone is. Now, non-medication related interventions that have worked and that seem to help in conjunction sometimes with medications if needed. Stretching, I want to emphasize, extremely important to stretch. These seem like, easy interventions, and some people are like, stretching is not going to help. But if you're committed to doing some of these non-pharmacological interventions for pain syndromes, you'll be surprised. I have had some patients where they were on multiple medications. They didn't feel so great because they were on 3 medicines, cognitive fog and fatigue. And once they got into a good regimen incorporating stretching, therapy, exercise, etc., they were able to come off of some of their medications. And I have some people that are not even on any medications for pain syndromes, and they're just doing non-pharmacological intervention. Positioning, of course, if you're in a wheelchair or if you have a frozen shoulder, positioning can help, and various other things there. So the more common medications that we use that are specific for spasticity are listed there. Now, as I mentioned with neuropathic pain, sometimes we'll need to use more than one of these medications in combination with each other. Because these medications work to decrease spasticity, spasms, they work on the motor system. If you give too much, people can get weak. So you have to be very careful in terms of giving too much. And doing combination therapy sometimes can allow the person to take lower doses of maybe 2 or 3 medicines and not have the side effects that we can see with these medicines. Now, for individuals who cannot tolerate the oral medications and still have a significant amount of spasticity, we'll sometimes refer them to get intrathecal baclofen pumps. I won't go through this because of interest of time, but the advantages and disadvantages of this intervention are listed there. I don't think this is for everyone, but I do think there are a group of folks that could benefit from this. above and beyond the oral medications and putting pumps in, we will send patients, at least here, to the physiatrist to help with Botox injections. Botox injections will relieve the symptoms of spasticity. Oftentimes, it's not very good for large muscles, but for small muscles, it seems to be a better. And then there are various other medications that can be injected as well. So in conclusion, I know I went fairly quickly, I apologize. So in transverse myelitis, the pain syndromes are very challenging to treat. And oftentimes we do need a multidisciplinary approach to treat the pain syndromes. And this can change over time. So when we see patients in clinic, we spend a lot of time reviewing what symptoms are changing over time. Are they better? Are they worse? And depending on the person's needs over time, we may have to do additional medication adjustments or even the non-pharmacological interventions that I showed. And I really want to emphasize the non-pharmacological interventions for pain syndromes, because I think a lot of people will just go to the medicine cabinet, grab a pill, and oftentimes that's not enough. And occasionally you can get away with just doing non-pharmacological interventions and be off medications. And then the multidisciplinary approach, you've heard me say that a couple times, I think is extremely important in treating neurological patients in general, and more specifically with transverse myelitis. Okay. Questions? Hopefully I can answer them.
I have a question about the pain medications, because TM patients suffer from depression and they're prescribed like Cymbalta and amitriptyline because they're also prescribed for pain.
Correct.
So that's true. But then some of the side effects are like suicidal ideation, and so is that tricky to manage, and how do you...
Yeah, it can be. It can be very tricky, and I always try to take the approach of being minimalistic when it comes to medications because of the side effect potentials. And if you can get away with using one medication, it can treat multiple symptoms, and that's a good way to go. For, you mentioned amitriptyline, so for individuals who don't sleep very well and they have neuropathic pain, it seems to be a very good medication at low doses. Cymbalta, as you mentioned, it can help with depression, anxiety, and pain syndromes. The suicidality that can come from some of these medicines is a tricky one, because here they're supposed to help, in a sense, prevent those really bad thoughts. But then in some individuals, it can actually provoke that. And so you have to be careful. And what I tell people, patients, family, students, that you have to listen to your patients and really try to tune into, are they having some of those bad thoughts that may be related to a medication, or could it be related to the situational? And you heard a talk by Dr. Kaplan earlier, so we'll rely heavily on our psychiatry colleagues to intervene if we really think that there's suicidality involved. Whether it's medication related or not, we still like to get them involved to tease some of that out. So, yep.
Hi, I wanted to ask you, do you ever promote a morphine patch, Equagesic? Do you ever use that in treatment for pain? And if so, what's the duration one can use it, or can just use it indefinitely, like a nicotine patch? Or
Yeah, no, that's a great question. So this is a tricky one, because we know narcotics can do a lot of bad things to the body, such as constipation, urinary retention. Occasionally, long-standing narcotics can cause what's referred to as a hyperalgesia syndrome, which is actually increased pain, which is not well understood. I personally have used some narcotics, both oral and patches. As far as how long one can stay on it, it really depends on the person themselves. Are they experiencing side effects that are not so pleasant from the medication? My personal practice is, if we have to escalate to a narcotic, I usually try to get the pain management folks involved, since they're more experienced than we are in managing some of these things. And again, that goes back to the multidisciplinary approach of treating. But there are some people that will require the narcotics. In my experience, though, if you're going to that level, you've already been through a lot of sort of that laundry list of medicines, and so you've already tried those medications, so it's not unreasonable to try narcotics in those situations. But my personal bias with narcotics is we try to stay away from it just because of the side effects. A lot of our TM patients will have bladder issues, bowel issues, and this could potentially make it worse. Absolutely. No, and that can limit your exercise, that can limit your physical therapy. We have plenty of patients say, well, I just can't do the therapy because every time I move my leg, it causes excruciating pain. And so that's where you have to work closely with your provider or providers to try to get a nice regimen of, if it's medicines plus some other non-medication interventions to limit the pain, because I have seen and I do believe that fighting through some of that pain initially has rewards long term. So there is light at the end of the tunnel. You have to occasionally fight through pain, and I know it's very challenging.
When you say providers, do you mean the doctors that everyone's working with, or the insurance company?
So we're not in cahoots with the insurance companies. No. So it's the providers, the physicians, the physician extenders, the therapists, the urologist, all the providers that are trying to help the patient. The insurance companies can be quite challenging, especially if you're trying to get certain medications approved and it's more than one medication. And so we do a lot of phone conversations with our insurance company friends. Yeah.
So we're recording this event, so anything that's not being said into a microphone isn't being captured. So I'm going to pass on the microphone to the next question.
My question deals with homeopathic therapy. My brother is one who suffers from TM, and he also suffers from a variety of other conditions, like I know a lot of people do, diabetes, high blood pressure, what have you, where you have to take medications for those in order to maintain a certain standard of health as well, all of which have side effects. And then, of course, when combined with these medications for the TM or the NMO or whatever it is you're taking, you're having to deal with, cause even more side effects. These collection of side effects, they end up causing the patient to do, just like you were saying, it becomes too much with the swelling, too much with the other effects in the body, so that physical therapy becomes almost impossible. There have been times when he had literally stopped. I can't do it anymore. I'm just not even going to keep any more appointments because it's not helping because I can't move. So there have been periods in time where he has just gone completely, like you said, non-pharmaceutical. And so although that may help for a period of time, there is a concern, UTIs come back, different things bring him back to the hospital. So my question is, what type of homeopathic therapies can be used for pain management specifically that we can start practicing, or if anybody has used with great success, so that we can start weaning him off of the extra medications that are needed, because some are absolutely required, like for schizophrenia, like for high blood pressure. You have to maintain. So what can you do that?
No, so it's a great question. So it's a challenging question to answer because the sort of bracket of homeopathic medicine extends very far. And so if we put it under alternative therapies maybe, or complementary therapies, as I usually like to mention, in there I will tell people acupuncture. I don't know if your brother's ever tried acupuncture. That often can help with pain. Specific medicines that are homeopathic, like naturopathic type medicines, it's a little less clear with those therapies how they work. There are some studies that have been done mostly in MS. There's a guy, Alan Bowling, out in Colorado, who's been sort of the pioneer for naturopathic or homeopathic medicines. And, occasionally these medicines can help. Specific ones, it's hard to say because, again, I think there are a lot of them out there that claim that they can help. What I usually tell people is it's okay to go that route, to take some medications or homeopathic remedies if you see that it says, this is for pain relief. With the condition, though, if it says anything in there about the immune system and activating the immune system or making your immune health better, you need to stay away from. And a perfect example is, echinacea is a over-the-counter remedy that's used for, when you get a viral illness, and that's supposed to boost your immune system. The problem with transverse myelitis and conditions that cause transverse myelitis, that's an overactive immune system. You don't want to boost your immune system. So you're actually, with the therapies that we do, in like neuromyelitis optica, multiple sclerosis, we're trying to taper down the immune system and not make it as active. And so you have to be very careful with that. With specific medicines, carnitine I'll mention, this is a medication that you can get at GNC. It has been used for fatigue. It's been used for spasticity. I've seen it help in some pain syndromes, other pain syndromes. The dosing varies. Usually we like to try to get people up to 3 grams a day with that. But that's a relatively safe medicine in my mind. The other thing, if you're talking about, it's not really alternative medicine, but complementary medicine, vitamin D is extremely important. I've seen many patients who, with these pain syndromes, have improvement in their pain when they're on vitamin D and they get to an adequate dose. We know vitamin D has a role in terms of playing on the immune system, decreasing inflammation by some studies. And of course, it's good for bone health. I don't know if that sort of answers your question. I don't mean to dodge the question too much. You have to be careful with a lot of things that are not studied in a rigorous fashion, because I have seen some patients, unfortunately, develop worsening symptoms from some of these medicines that aren't tightly regulated.
Okay, last question.
If a patient really hasn't had much in the way of spasms over the last 18 months, 24 months, and all of a sudden the spasms start to increase in the legs, would that trigger the bladder to make incontinence a problem? Is that possible?
Yeah, no, it's a great question. So if you're having spasms in one part of the body, that's a muscular contraction. And we know the bladder is a muscle. And so there are some patients that will have, in isolation, sometimes even to muscle spasms in the legs, bladder contraction that can cause incontinence. But I have seen some patients with, depending on the level of the TM attack, that can cause bladder involvement and spasms, and they can go in conjunction. And on one of the slides that I'd mentioned before, the spasticity and the spasms that we can see can happen 18 months or even 2 years out. And it depends on how you look at these things. With pain syndromes specifically, if someone is developing pain syndromes after the TM attack, in my mind, that's not such a bad thing, because that means that things are trying to repair. The tricky thing is still treating those pain syndromes. We're happy that they're there, because that does mean that connections are trying to be made, but unfortunately, in some cases, the connections are not being made completely, and that's where these pain syndromes can occur. So we're hopeful, though, with some of these stem cell therapies that are becoming down the pipeline, that will help repair some of the damage or complete the repair, where that can actually improve quality of life, getting rid of pain, maybe even spasms.
Thank you, Dr. Newsome.